Permashore.
Okay. Good morning, everyone. Welcome to Pediatric Grand Rounds. Today's speaker is Dr. Stephen Griffin. He is a third-year resident at Carilion Pediatric Residency Program and will be graduating soon. Dr. Griffin was born in Marshall, Virginia, and is a graduate of Lake Erie Osteopathic School of Medicine in Erie, Pennsylvania. During his time in Roanoke, he performed admirably. His QI project focused on bridging care gaps by decreasing the rates of uninsured patients in pediatrics by working to increase placement by putting a DSS worker in the local library family. Dr. Griffin has been the recipient of the Resident Teaching Award from Virginia Tech Carilion School of Medicine and was recently inducted in the Gold Humanism Honor Society for clinical excellence and humanistic curative medicine. He will be taking his talents and moving to NRV to work as a hospitalist upon graduation. Please join me in welcoming Dr. Stephen Griffith today.
Alrighty, thank you for that, Dr. Permashore, and we'll dive into some pediatric grand rounds. I do have the chat up, so this will be a little interactive. If you have questions, feel free to throw it in as we go. I did invite everyone to wear like a jersey or sports apparel or anything like that and have their cameras on without realizing that I won't actually be able to see anybody because I can't see the video screens or the participants no matter how much I played with it this morning. So hopefully I'm not the only one. But today we'll be talking about pediatric concussions and diving a little bit into chronic traumatic encephalopathy. But again, I'm one of the third years and working for grand rounds. I was working with Dr. Wilson and Dr. Blackwood. Dr. Wilson, who's our pediatric neurologist, and Dr. Blackwood, who is helps in our adolescent clinic and also does a lot with sports medicine with Salem High School, I believe. So we'll kind of dive right into it. I still have no relevant affiliations, haven't picked up any fun sponsorships or anything in residency. And here's the objectives that were sent out, things that we're just going to briefly touch on, so I won't read all those to you, but things that we will hopefully hit today. So why would I do this talk? As I was going through everything, I kind of ended up feeling a little bit like a statistic. But you'll see that the earlier you can start sports, and there's some pictures of me growing up, but the earlier you start sports, the more concussive and subconcussive impacts, especially contact sports, you can get throughout life. And it's just like CT, the more earlier you get CT's imaging radiation, the longer, more lifelong exposure you have to that. And you know, you get headaches, you brush them off, you get hit in football or contact sports and you don't think about it. And then you get that one that you can't shake off. You end up in the ED, intractable vomiting. You know, your parents are worried after a football game, and it shows you have, you know, a brain bleed and kind of retire from sports at that point. And this was actually a true story. This is a story about me. But, you know, even after retiring from football, you know, so to speak, in 10th grade, I had 9 seasons of full contact football under my belt starting, you know, 3rd grade on. And, you know, there was plenty of times that you had that lingering concussion that you shook off, you didn't really think much of, you didn't tell anybody. And we're going to dive a little into that today and why that's probably a bad idea. And some things to think about, especially as parents are asking you in the clinic, when can I start sports? What sports should I start? You know, concussion has been in the news a lot. And so hopefully give you a little better understanding of that. But we'll keep going on. So the biggest thing is definition. What is a concussion? So it's also known as a mild traumatic brain injury. They're also trying to get away from using the term concussion, which is unfortunate because it rolls off the tongue, and they want you to use mild traumatic brain injury, which I'll try and stick to the vernacular during this talk, but I will most likely slip up and say concussion quite a few times. And the reason for that is when they've done some studies and looked at it, concussions seem to minimize the severity of symptoms to the parents. You know, they'll say, oh, it's just a concussion. Oh, they can go back to practice. Oh, they don't need to go to the doctor. Again, it's just a concussion. So really calling it that mild traumatic brain injury kind of puts the import a little bit on the parents and makes them realize that this is a severe injury. It is brain trauma, and they need to treat it as such and not really minimize those symptoms. So again, moving away from using that term concussion, but just like anything in medicine, slow moving, and everyone's used to saying concussion as well. So definition of the mild traumatic brain injury. So it's acute injury resulting just from mechanical injury to the head, and it doesn't have to be directly to the head either. So if you get a big hit to the body that kind of transmits to the head with that whiplash injury, you can really get head trauma to that as well, even if it's not directly to the head. You don't have to lose consciousness. You can, but not all concussions or mild traumatic brain injuries are loss of consciousness. You can have confusion, disorientation, post-traumatic amnesia for less than 24 hours. So you don't remember what happened around the hit. Everything's kind of foggy or fuzzy there. And then they put this kind of global catch at the end of it of other transient neurological abnormality. And the reason for that is they wanted to err on the side of caution. They would much rather, sit a kid, bench the kid that didn't need to be out than letting them go back in with, possible brain injury going back into play. And so that's why you get that kind of global catchment there, which is pretty much anything is abnormal or concerning, you just take them out. And then obviously, if you have a deviation from your GCS, I hope you're not sending this kid back out to play 15 to 30 minutes. Or the other caveat is presentation to healthcare. So, they're playing in a game maybe Friday night and, they go home, they're not worried about symptoms, but Saturday morning, something's still not right. Parents bring them in to get seen. So all of this can start from there as well. And so what symptoms are you going to see with these mild traumatic brain injury? So obviously you get hit in the head. Your biggest one is going to be headache. It's the most common symptom that you're going to see with this. Excuse me. But you may also see light sensitivity, noise sensitivity, especially with how much electronics are wrapped up in the world now with the pandemic. And your second most common is going to be dizziness, kind of followed by difficulty concentrating or confusion, that kind of like fuzzy, foggy brain that they might describe. Again, loss of consciousness not required. It is kind of a slam dunk if they do lose consciousness. But this is kind of a long list of non-specific symptoms a lot too, which can make the diagnosis and treatment of mild traumatic brain injury kind of hard from the kind of pediatric standpoint. So a couple questions. Now, I've given you the brief, broad overview of a concussion. So we're going to run through like 3 questions, throw your answers in the chat, and we're going to identify some concussions to give us some on-the-job training. So is this a concussion? Player takes a hard hit. He's unconscious on the field for less than a minute, has no idea what happened, doesn't remember the hit, just kind of remembers being on the sideline. So yes or no concussion, you bench them until they follow up, or no, they're good, shake it off and send them back out on the field. All right, so some people are chiming in. Yes, Dr. Tiffany, definitely bench them until follow up. All right, so then, and I'll give you the hint that this is a talk about concussion and mild traumatic brain injury. So player took a hard hit during the game the night before, kind of wakes up the next morning, still having a headache 24 hours after the game. He's kind of taking the day easy, playing video games, but the light, the noise, everything is kind of hurting his head, making his symptoms worse. So is this a concussion? Bench them until further check out, but they check out further, or return them to play on Monday next practice. All right, and we have some more answers coming in. Yes, this would also be concerning for those symptoms, so bench them until further evaluation as well. All right, so last one. You've been the team doctor for quite a while. You're on the sidelines. Players know you by name. You know them. You've been there for a while, kind of end of the season, so you're familiar with everybody. And a player gets hit on the field, but is otherwise doing fine, comes off at change of half, and they're just not really acting like you normally see them. They insist they're fine. You're talking to them, and they're like, no, everything's fine. I want to go back out and play. So yes, is this a concussion? Bench them until further follow-up? Maybe bench them until further follow-up, or no, they're good to return to play. They're insisting they're fine. They're good to head out. All right. So, and we have some people kind of hedging their bet that maybe, and maybe we should bench them to check out. which would be correct. So when in doubt, just pull them out. It's always better. That global caveat at the end, if there's anything concerning, take them out until they get checked out. It's always better to miss a game than to, end up with some further issues down the road. And keep moving on. But what the video kind of touched on a little bit in the beginning is kind of incidents, mild traumatic brain injury, or, there's some papers that'll call it sports-related concussion or concussion. There's a million different terms, are very prevalent. Just from 2005 to 2009, 2 million outpatient visits. So these are the, kids that woke up, felt bad, but weren't taken off the field right to the ER after the game. That's 2 million visits alone. And then there's also 3 million ED visits for concerns over this mild traumatic brain injury. And you may get the parents coming into clinic saying, what sport can they play? What's the safest? How do I not get my kid, a concussion or a mild traumatic brain injury? Unfortunately, this is your incidence table here on the right. Tackle football is number one by far going to be the leading cause of your concussion rates for sports in high school for boys, and then for girls, soccer is going to be your number one there as well. And you might, hear people say, "Oh, I want to do, track and field because I won't get hit in the head." There was even some concussions with track and field too. So anyone that, has kids or, is taking care of kids enough realizes that most kids will probably find a way to accidentally hurt themselves at some point. Just there's certain sports that may carry more of a risk with that as well. So now we'll dive into a little bit of sideline evaluation. So you're the, team doc, or maybe you're there with your kids, and they, a kid gets hurt or something like that, or you have to, make that decision of, is this, do I need to sit them out, concern for mild traumatic brain injury? So first thing is going to be a good neurologic exam if they're awake and with it. If it's focal at all, go ahead and sit them out. If there's pupillary issues, anything concerning, go ahead and sit them out until further evaluation. Doing a quick, like you learned in med school, kind of mini mental status exam. Obviously, these are older children, not like the, tiny tots football or anything like that, where they might not be able to do serial sevens before the game. So that's not really going to help them out. Checking their gait and balance. And again, like we said, if there's any doubt, go ahead and sit them out. Another caveat that you may not come to mind, especially in high school sports, if they are driving and they drove to the game and you're concerned, they are not allowed to drive home by themselves. Kind of a common sense point, but one that brought up, and I was like, oh, that's, maybe something we might not be thinking about. After you check them out, they get on the bus, they drive home or ride home, and you think they're kind of good to go. So if the player is unconscious, you have to assume C-spine injury first. So stabilize the C-spine. There's usually, especially if it's a game, EMS or paramedics on standby to help with that. And then ABCs, just like any patient, especially, for any unconscious patient, make sure their breathing is doing okay, the airways are clear. And then if they regain consciousness, try and assess their C-spine. But if they are not with it, they're not lucid, they're totally out of it, or you get numbness, tingling, just assume C-spine injury. You can't trust a patient if they aren't quite with it. And then try and take the patient in for their sideline eval off the sidelines. There's a lot of things going on, a lot of distractions. So you want to take them to like a quiet, locker room, somewhere else that will allow for a more thorough evaluation. So we're going to dive into a few sports-related kind of assessment tools that can help us out. The big one is called the SCAT 5, and I'm going to drop the PowerPoint and share this and walk through it. But I'll also send this link out, or the link to the page out afterwards, so you guys can go through it. And it's also just fairly helpful to kind of have in your back pocket, free online. You can download it, print it, fill it out. But it changed a little bit from the second version, and it seems like every time this symposium on head injury gets together, there becomes a new iteration of this assessment tool. But the big thing they changed is they put this big, on the first page, big red flags symptoms checklist. If there's any concern about this, they're done playing. They need further evaluation. Some of these are obviously more concerning, intractable vomiting, deteriorating consciousness, altered mental status. I don't think anybody here is going to send them back out to get evaluated or to go back and play before they get evaluated. But these are just kind of your stops there. And the form is nice because it takes you on a step-by-step process through basically evaluation of the athlete. So you start one, and it's even numbered. I'm going to pull it up. Red flag symptoms, then it goes to observable signs. And these can even be like mom and dad took a video and they showed up to clinic the next day with their headache or their symptoms, and you can watch the video and use those observable signs and symptoms for possible head injury. There's a memory assessment, the classic GCS, there's a gait and balance section, a C-spine assessment. Again, if the player's not there, you can't quite trust that. So let me drop the PowerPoint and then go ahead and share the SCAT 5. So you can see it's even got areas to write all your patient information down. But we'll scroll through it and just briefly touch on this. And it gives you numbers and scores to check as you go and kind of grade it up at the end. This can also be used over time, like in an outpatient setting. So they come in, they score poorly on it, lots of symptoms. You can start actually doing it multiple times over time and track their scores to watch it improve and as they get better towards that full recovery. So here's the observable signs. Lying motionless on the playing surface, facial injury, blank vacant look, disorientation, confusion. And then there's the memory question. So kind of quick, easy mental status exam. Where are we? What half is it now? Who scored last? What team do you play on? When I had my concussion that I never, left the game for a little bit of time during the game, didn't remember what team I played for. I just stood with the one wearing the red jerseys. So again, concerning, but concussed high school athletes don't make the best decisions mid-concussion. So your GCS is listed out here too for you to grade this up as well. C-spine assessment. And then you get that first page is that quick and dirty sideline assessment. And then your second page is going to be more you can do things in the office. So it takes some history, and then you even have this symptom checklist here. And we'll get into it a little bit with recovery, but the more symptoms you have at the beginning, the longer your recovery is going to be from this head injury, which is kind of common sense, but there were studies to back that up as well. They call it a symptom burden or a symptom load at the beginning. And the more you have with that, the more issues you'll have overall. Then you have your cognitive screenings, immediate memory, and then you give them some words, just like doing that mini mental status exam, and then try and have them recall it at a later time. And then when you get towards the end, you can calculate all of this up into your kind of clinical decision, how they scored, and track that over time. There is the caveat that no single one kind of metric or grading scale or anything like that should be used to clear somebody. Obviously, if you pass the SCAT 5 with flying colors, but you can't you can't go back to school, you're having persistent headaches, anything like that, or you just straight up lied on the SCAT 5 because you want to get back for like states that day or something like that. Clinical decision making is going to come into it. So that as part of the new kind of symposium guidelines was there's not one that is, hands down, use this one. And we'll get into some other testing next as well. Also, there was, I believe they said something like over 30 different, validated forms. So it's almost like you search one online, you'll find a million of them to use, just with the one that you're comfortable with, and then also your clinical decision making has to come into that as well. All right. So like we talked about, it can be used to follow your progress of recovery. You can quantify them into like a score instead of just nebulous symptoms. You can use these as a baseline if they're high risk, high contact positions, or maybe you're the team doc for many years and this kid had 5 concussions last year and keeps trying to play, and you want to get a baseline to see what's going to change. You can do that prior to any injuries at the beginning of the season. So when should you head image these kids? So people that work with kids have probably heard a lot of the PCARN scoring. That is just as applicable here as it would be anywhere else. So any concerns there, then you should probably pursue further imaging. Again, deteriorating level of consciousness, concern for C-spine injury, any focality on neuro exam, seizures, intractable vomiting, kind of concerns for intracranial pressure. You should probably get some imaging to rule out more severe pathology. This is a brand name, so I apologize for using it. I have no relation to this company. This is just one I'm familiar with because they used it a lot up in Pennsylvania where I did my clinical rotations in med school. But it's called impact testing. It's a computer-based testing that can be used kind of like the SCAT-5 to see how people are doing after concussion and how they are improving along the way. But the caveat with this is it should be there should be a baseline, and a lot of clinics around kind of pre-football season, summer physicals was come get your physical and your baseline impact test before we start the season. So it was kind of like the new hotness when I was doing med school down there or up there, and they wanted kind of everybody to get impact. If you played a sport, you got an impact test, didn't matter what it was. So it's only valid for 12-year-olds to 59-year-olds, and it's you proctor it. The trainer at school can do it, or nurse, doctor, anything like that can just proctor it. Basically, you're watching them to make sure they're not cheating on the test. And the questions are actually individually timed too, and it tests these areas listed below. But the reason the questions are timed is if you get all the questions right, but it took you 3 hours longer than your baseline, you're not cognitively back to normal, and you're not ready to go back and play again. And then how do we get kids back in to sports? They want to get back to play. And so we'll dive into kind of how the AAP recommends that we should do that. But again, you take a hit, you have any issues, you immediately remove them from play until they make it through this return to play process. So some light cardiovascular activity, walking, something that's not going to establish, return of symptoms, the worsening headache, anything like that. And so even if, walking is causing that the first day, maybe let them relax, be a couch potato at home for a day, something like that. But you can advance them as we go through this as long as they're not having symptoms. And teenagers, especially with COVID pandemic, electronics have become our only way to leave the house, evidenced by giving this talk through a computer at home. But there's no evidence to date that has shown detriment to electronic use. It doesn't extend your recovery as long as you're using them well. So if, lights, you're photophobic, you're phonophobic, lights and sounds are bothering you, make some adjustments to the electronics. So turn the brightness down, put the blue light filter on, maybe take more frequent breaks from it. You don't want to be exacerbating symptoms, but what we've seen during this pandemic is, their social life is on their, smartphone in their pocket, texting, Facebook, social media, all of that is on there. And what you don't want to do is take this athlete that may have some mild, even psychological disturbance with their head injury and basically put them in a dark room, isolate them from the world, take their electronics and say, stare at the wall until you feel better. That's going to actually prolong their recovery and just be kind of negative experience overall. So to really try not to socially isolate the athletes as you're letting them recover. All right. Other things. So driving tests, school tests, anything like that, don't let them do that until they're kind of fully recovered. They're not going to do well. But they're also have seen that after your traumatic brain injury, you are not able to identify road hazards, as well. And if they are driving beforehand, don't let them drive home. Kind of grade them back into it. Have someone with them once their symptoms are resolved and they're back to activities of daily living. I would have somebody with them. Make sure, give them a couple test drives, make sure they're doing okay before you kind of release them to drive again. And again, even school tests, try not to get them to do school tests, or if they take it, work with the teacher and say, hey, maybe this is, we take it, but the score doesn't stick. Especially with the COVID pandemic, we've seen that, online school, there's so much work, a kid misses something or fails something, and they're so behind and they're just basically drowning, trying to climb back out of it for the rest of the semester. So until they're totally back to baseline, try not to take any big exams or anything like that. Then if they have that persistent vertigo, persistent dizziness, you can have them go to PT or your friendly neighborhood DO and see if you can get the Dix-Hall-Pike maneuvers and the Epley maneuvers to kind of realign all that and see if that can help make the vertigo go away. The AAP recommends this graded return to play system. So step one, you're going to hit each step for 24 hours. We'll talk about, but step one is you're back to regular activities. You can sit in school. You can, move around the house, do some chores, stuff like that. You're basically your activities of daily living, and it's not causing you symptoms. Step two is your light aerobic activity, so jogging, walking, but again, not causing you symptoms. And we step it down through all these listed above. But you need to be able to do step five, full contact practice. You're taking hits. You're not having more return of symptoms, headache, dizziness, even mood symptoms, and before we can return you to the game. So in the absolute fastest way possible, if you get, a mild traumatic brain injury, and I would say very mild, Friday night, and the next game is next Friday, you could potentially, with no slip ups or step backs, make it through all of these to play in the next game. But again, if the parents have concerns, always better to sit them out as well. But you have to pass each step of these with 24 hours of no symptoms. So if you're doing that light walking step and that evening, you walked around all day and that evening your headache comes back, you don't get to move on to step two. You rest for 24 hours and then you just take it back stepwise until you hit that level that did not cause you symptoms for 24 hours. And that is just going to be the process until they're able to step through that. And even if they're, lifting, running, doing all that physical activity, but they're not cognitively or academically back to baseline, then they're not ready to go back. They're not ready to return to play because their symptoms have not resolved. Even if they're able to make it through that, and remember, step one is that activities of daily living, and also one of those is going to be school for kids. So some risk factors that can kind of tip you off that they may have a prolonged recovery is the presence of ADHD. We talked about that high symptom load. So if you go down that table I showed you at the beginning and they're checking off everything, they're probably going to have a prolonged or longer course to recovery. Loss of consciousness, the younger they are, the more damage they're going to have. And then presence of ADHD, other, anxiety, depression, because that's going to be hard to pick out from that mood change in that cognitive symptom checklist. And so that's going to make that longer recovery too. There are also many studies listed female sex. Just that's what came out when they did the research. And they did propose some risk factors or reasons for that is just less muscle mass in the neck causing more of a whiplash injury because when they tighten their neck, it just can move more. And also, they also found that, for the benefit is that girls and female athletes were presenting to get checked out more often. Again, guys were not coming in to get treated. They were ignoring it or just not paying attention as we're wont to do. So we should take a page out of their book and actually get checked out if we have symptoms. So serial assessments can help out, especially if they have prolonged recovery. And that's going to be anything kind of over 4 weeks, that kind of post-concussive syndrome, which is touched on in the video, but we're not going to really dive into that today. And again, the more symptoms you have at the beginning, the longer it'll take. But for mild traumatic brain injury, I think it was 80%, most patients will recover between 1 and 4 weeks and kind of be ready to go back to everything from there. Another question that may come up with families is, when should I retire my student athlete from sports? Some people may have some old guidelines floating around, but there's no magic number of concussions or head injuries that, say, oh, you hit number 5, it's time to stop playing sports. If you're thinking about retiring a kid from sports, especially as kind of the PCP, it may be beneficial to send them to someone who specializes in concussion, specializes in sports medicine, kind of get their opinion as well. And then considerations for retirement. I threw some NFL players in there that may benefit from retirement, but following severe or life-threatening injury, so you have a significant brain bleed, you should probably look at retiring, maybe from that sport as well. But again, these are all recommendations, not quite hard and fast guidelines. If you have persistent symptoms, persistent headaches, these are clearly symptoms that are not resolving. So you're basically, you can say you have not recovered from that head injury, and it may be time to retire at that point. Multiple concussions, so 2 in 1 season, 3 lifetime concussions was an older guideline that's still kicking around somewhere. And there was some talk about kind of this chronic traumatic encephalopathy. But again, it's a post-mortem diagnosis. You are basically just risk stratifying throughout life, and you can't tell until the patient passes away and you're able to do frozen sections of the brain. And so that's a thought, but there's nothing that we can tell during life that, hey, you're developing this, it's time to stop playing. So now we'll briefly touch on this as well, but what is chronic traumatic encephalopathy? Some older names are punch drunk, that old boxer that doesn't really understand a whole lot, or dementia pugilistica to get the Latin name. But it's basically chronic and progressive neurodegenerative. They call it a tauopathy, but as you can see below, there's multiple other molecules involved. They've seen amyloid B, phosphorylated tau, which is the p-tau, and then alpha-synuclein. And what they're seeing is after episodic, single, or even repetitive head trauma, just leading to kind of this neurobehavioral changes. And they see that these molecules become tangles and clumps next to the vasculature of the brain. So they think that actually helps break down the blood-brain barrier. So they call it a cascade of neuroinflammation. It's proposed that even after the hit, all of these tangles, clumps continue causing some damage even outside of the hit. And it's seen more with repetitive, prolonged traumatic brain injury. It's worse when you don't fully recover and you get back out on the field too soon. You're getting those second impacts and more damage to the brain while it's already still trying to recover from the first one. And then that disruption of the blood-brain barrier leading to imperfect repair, inflammation, and we'll get into it, but some changes down the road. So again, like we talked about, it's a pathologic diagnosis. They currently don't have any blood tests. There's no imaging tests that aren't being used in research studies. And they've broken it down into some syndromes. But there's behavior predominant. This is seen earlier, 30s, 40s, depending on how many hits to the head that you've had. It's seen an increased risk of suicidality, increased risk of substance use. Another one is just mood predominant, so behavioral dysregulation, mood disorders. And then older is Parkinsonism. And so again, without that pathologic diagnosis and slides and sections to look at, it's hard to differentiate. This person is elderly and developing Parkinson's symptoms. Is it just Parkinson's? Or is this due to CTE? And until you have that, it's hard to delineate. And usually doesn't present with just isolated motor neuron disease. It's usually behavioral as well. So the first thing you'll get as soon as you start researching this is a ton of articles and a slew of evidence and things titled like, is this real? It's not real. It's a fake disorder, disease. But again, it's still, fairly new and people are doing research on it even still. But this was an article I pulled up that was very interesting and really kind of caught my attention because it's written with such inflammatory, title. The title was CTE is not real and like everything was fake, essentially was the title of the article. And it's presented very much like a journal article. So to, make that not, I don't want to use the term like fake news, but it's made to look more than what it is. And it turns out it was just an editorial article, almost like a letter to the editor. But there was references, footnotes everywhere. It was presented very much like a journal. Even the source I pulled it from touted it almost like a journal. And it states that players are less likely than their controlled peers to commit suicide because professional athletes, basically their lives are so good, they're getting paid while they're comfortable, and they're less likely to have poor outcomes. So CTE can't be real because of that, because they're healthier than other people because they're top tier athletes, which is probably true that they're healthier. They don't have the high cholesterol, hypertension, the obesity. But again, I think it's hard to, just flat out say this is not, nothing's happening with multiple brain injuries throughout your life. And they pulled some other things that were showing, well, other people had phosphorylated tau and they did not have CTE, or maybe they didn't play contact sports. And they did also bring up a good point, which a lot of the CTE research is biased, but it's a selection bias because they're asking for brain donations. Obviously, you can't decide that we're going to brain biopsy everyone who's ever, at one age group who's never played contact sports and who has played contact sports and compare the two. I don't think any IRB will ever sign off on that. But you're getting players, professional players, their families are bringing, donating to the brain bank that they're making these frozen sections from. And it's because these players had issues in life, had symptoms of CTE, and so you are getting that selection bias. So that point is well made. But then as I delved into it and kind of looked up the author, he claims zero affiliations, just like we have to claim our disclosures. He has no bias. But then it shows that he was the neuropsychologist for the Chicago Bears for many, many years. So again, it's a contentious point, definitely, but there's lots of ongoing research for this. And so where does the AAP stand? So some of these are kind of common sense points. Repetitive subconcussive hits, getting hit in the head over and over again is no benefit to the sport of football. No, but it is a part of the game. And this was talking about football in and of itself. So, but you can think about, getting repetitively hit in the head is really not making any other game more beneficial. It just happens due to the way the game is played. They also thought that delaying tackling until players are older will reduce these total subconcussive hits, potentially lowering rates of concussions in pediatrics. So again, you start at a later date, you will therefore have a lower lifetime incidence of hits. And there's a big caveat on the next slide we're going to dive into. And then cervical muscle strengthening can certainly help. It's not going to hurt anything, but it's not going to stop you from having a concussion. Same as you might see those mouth guards that are supposed to help with concussions. No one's going to fault you for protecting your teeth, but there's no mouth guard that's going to magically make your concussion go away or protect you from them. And then, coaches and officials should, protect you from the rules or keep you adherent to the rules that are designed to protect you, such as no spearing, no head-to-head hits. These are a lot of the new rules coming out recently that some people, more older school system may say is kind of ruining the game, but they're there to protect people and keep them healthier longer because your playing days will end, but you still have to function as a human being. And then expansion of no tackling leagues, such as like flag football, should be considered as well, doing that early on. But that big caveat about, starting tackling in full contact later, they actually looked at that with Canadian hockey players. And took young kids and kind of put them in a league that did not have any body checking that was allowed. And they did notice that there was more severe injuries. So I think it was until they got like high school age, but they didn't have any tackling. But then other leagues around the area did. And so suddenly they graduated into a league where it was kind of open season. And we weren't seeing more severe injuries in that study because they just weren't used to it. If you're about to get hit, you're able to tense up your body, you're looking for it, it's something part of the game that you're expecting. And these kids have gotten used to basically not having any of that risk of being checked into the boards. and they've gotten used to that system. And so they saw more severe injuries once they did kind of get thrown into the meat grinder, so to speak. And then overall injury was delayed or was decreased by delaying body checking. So you put off injury longer, but it was more severe once they entered that league. So it may not be the fix that the AAP was hoping. And then you'll get, should our patients play contact sports? Questions parents will ask when they come in for their sports physical. So exposure to contact sports before the age of 12 led to earlier onset of neurobehavioral changes and symptoms. For every 1 year under 12 that a player started contact sports, the onset of these symptoms increased by 2.5 years per year under 12 that they played. And then another very interesting study from Radiology journal actually was they took 8 to 13-year-old kids after one season of tackle football and did MRIs, basically measuring the fiber density and diameter of the axons. And they noticed changes decrease in that in the white matter tracks after just one season. And these were not delineated by kids that had concussions, kids that had injuries. These were just, they played football. That was their only risk factor, and they were already seeing changes. But again, you can think back a couple slides where younger injuries or younger age, younger pubertal stage is going to lead to more severe symptoms and severe injury. And these are pretty young kids, so maybe that plays into it as well. And so should patients play? Again, the AAP is not making any distinct stance on this. It is going to be a personal decision for the families. Best we can do is kind of arm them with, what we know and some clinical decision-making tools, and kind of hope, that they make a good decision, or, they want to play and you let the kids play. But if, they start developing those injuries, those mild traumatic brain injury symptoms, you can kind of help guide them from there. If they need to sit out, they need to sit out. And then we talked about some non-contact sports leagues, like flag football. These like 7-on-7 drills, stuff like that, can delay the onset of this repetitive subconcussive hits and impacts and tackling. So there are resources for parents out there. The CDC has a lovely page of Heads Up. So the link is up here. And I'll again send that out with all the stuff afterwards to everybody. But it's got a lot of information out there. It's even got some forms and assessment tools, I believe, for the provider to help identify mild traumatic brain injury in these kids. And it's a lot of information for parents too. So it's a good resource. Again, vetted by CDC. So it's helpful for everybody. All right, so we'll run through the MOC questions, then open it up for questions. If Dr. Wilson, Dr. Blackwood have anything to chime in, they're more than welcome to as well. So this is pulled off Med Study and Prep, and you'll see the Prep question because its STEM is about 3 years long. But you are a team doctor for a local high school football team. A 16-year-old player gets hit hard and is helped off the field, complains of headache, nausea, and dizziness, but there's no loss of consciousness. What management stage is appropriate? And I'll let you read through the answers and kind of throw them up in chat as we dive through this. All right, we have some hedging hedging of bets as well, but there's potentially A, which is right. So this would be classified as mild traumatic brain injury. Yes, there was no loss of consciousness, but he's definitely symptomatic. Took a hard hit to the head. He's complaining of all those symptoms. So he has to make it through each of those stepwise return to play for at least 24 hours without symptoms. You don't want to socially isolate your patient. And he's not allowed to return to the game that day. If you get a hard hit or a concussion, you don't get to go back that day. Even if you feel totally fine, you have to sit out the rest of that day from physical activity. If he begins intractably vomiting, kind of decreases in mental status, that would be a thought to need the CT to further. But if he's just a little nauseous and dizzy with a headache, you may be able to hold off. So question 2, 14-year-old male comes in after being sacked in a football game 3 days prior. Brief period of amnesia, doesn't really remember a lot around the hit. Headache lasted 24 hours. Didn't have loss of consciousness. His gait's normal. They ended up CTing him, and CT is normal. Which of the following represents when he may return to sports? Yep, and we got some answers chiming in. So it's going to be B. They have to make it through that six-step graduated return to play protocol, and then once they're making it through that, they're not having symptoms. They're clear to go back to kind of full contact competition play. I didn't touch on this briefly, but what they've noticed is the reason that there's a delineation between full contact practice and full competition play is your rates of concussion are actually much higher during competition play as it is during just regular practice. And the reason for that is likely kids are playing, harder. They're, really trying to win. They have that competition, that competitive edge, and they're going to get hit harder, whereas they may just be, kind of going through the motions a little bit at practice sometimes. All right, last question to get all the CME points for this, but 17-year-old soccer player had had a concussion 3 weeks ago, evaluated for clearance for return. She's full resolution of symptoms, remains asymptomatic, and she's returned to her previous level of academic achievement. This is her third concussion. Her first concussion was at 14, second was 6 months ago. Recovered from all of these. She's eager to return to practice, would like to be cleared for sports participation. Mom's concerned about another concussion. I think that's a fair assessment. And her neurologic exam findings are completely unremarkable. So, of the following, most appropriate advice for this patient is A, B, or C. So, she has met the criteria for recovery and should be cleared. Needs computerized psychological testing, such as like that impact we talked about. Need to perform a trial of high intensity exercise and report any return of symptoms, or should retire kind of based on current recommendations. So a mixed bag a little bit here, just to give Dr. Wilson and Dr. Blackwood a chance to chime in as well if they wanted to. But some A, some for C, and she needs to perform that high intensity exercise. So again, kind of theme to these questions, hasn't made it all the way through that six-step process yet, because she's only been doing light strength training and walking. So you need to kind of really challenge her to make sure if anything else is showing up. But here's some references through there, some recognition of Dr. Amalu and Dr. Ann McKee, who really put out a lot of these articles where they seem to be really kind of driving the edge. That from Dr. McKee's from Boston University. Dr. Keys was asking if there's any comments about contact sports in the age groups from 8 to 12, where you have a mix of prepubertal and children entering puberty. So I didn't see anything directly, Dr. Keys, about like mixing these age populations. Just that it puts them at a higher risk for prolonged recovery, just due to prepubertal age being leading to kind of more severe mild traumatic brain injury. And then that journal from the radiology where they saw just changes in that 8 to 13-year-old age group. But again, that was more treating the image, not the patient, because they saw these changes, but again, these kids didn't have injuries. They just saw white matter changes due to playing in sports. And then and I'll leave it open to any other questions, or if Dr. Wilson or Dr. Blackwood have any things they want to talk about. I will say something I picked up from Dr. Blackwood putting this together was I had an initial concern of, are these high school athletes going to be less than forthcoming to try and kind of get back into sports? Might they lie a little more? And he was saying in his experience, he hasn't seen that a whole lot. They're usually pretty forthcoming and not being subversive on their concussion evaluations or trying to get back too soon. And I think this might have been a concussion talk that you gave us, but high schools in Virginia now have to have like a concussion plan, a plan of action, I believe, um, kind of to help alleviate symptoms and make sure, we're keeping kids safe.
That's correct. That's correct.
All right. I'm not seeing any more questions in chat. If anybody wants to chime in or anything like that. If not, we can kind of wrap this up early and let you guys get back to morning clinic.